Good afternoon, this environment. Today I will be presenting cystic ovarian degeneration. This condition is what is reproductive disorder affecting the fertility, productivity, animals, and economic growth in the life of farmers. Now, what is cystic ovary? So there are a number of structures which can depend on the ovary, but how to distinguish whether it is cyst or ovary? These are the reproductive structures which are present on the ovary or within the ovary. They can disrupt the normal physiological function in the animal and usually greater than 25 mm in size and persist for more than 10 years. Now, what are the types of ovarian cysts? These are broadly classified into two types. One is the ovulating, second one is anovulating. So, ovulating cysts include cystic ovarian and anovulating includes follicular and nucleus. Cystic ovarian. So, sometimes what happens is normal serial forms, but there is interfollicular fluid which remain inside the seed, which leads to the formation of cystic ovarian. There is no difference between the function of cystic ovarian and normal seed. This is not pathological, this is physiological, and can support pregnancy. Now, second one is follicular. So, sometimes what happens is there is decrease in the pulsing of the DNA, which leads to the absence of LS cells. So the dominant follicle fails to ovulate and induce, and this leads to the formation of the follicle. So the structure is involved, usually less than 3.5 and filled with intrafollicular fluid. This, if you can see the USD finding, you can see that in this cyst formation, the fluid is anovulated. This is you can distinguish from the luteal cyst that there is a cover-like structure that is in the luteal cyst. As this is follicular cyst, it will produce similar amounts of estrogen even higher than the normal follicle, and the animal will remain in the estrous phase and prolong estrous phase. These are the two ULGs. You can see that both are having anechoic structure and the size is large than 25 mm. Now there is a postmortem. You can feel that there is very remote. If you can use a per-rectal or non-rectal palpation, they may rupture. Now third one is the routine. So sometimes what happens after the formation of the follicular cyst, there can be a little bit surges of LS, which can be supravis. Means the level of the LS will be higher than the basal level, but less than you will call it a surface. So at that time, there will be a little bit utilization of the follicular cells, and which further leads to formation of this nucleus. So as there is utilization has already happened, so there will be normal formation of the P4 level, but usually less than the one we can get by pregnancy. As the P4 is higher, it will be any stress because there is the absence of the stress, no signs due to absence of stress. Now you can see that the wall is clearly distinguished in this cyst. It's greater than 3.5 mm in diameter. This wall in the postmortem view, you can see it is harder and it won't usually get ruptured by the transcriptive palpation. And in the upper, in the USD, you can see that hypoechoic forward-like structures, which are shown as hypoechoic structures in both displays. Now, what is the etiopathogenesis of this cystic ovary? So, as you know about the two sides of the hydrographic beauty, it is all maintained by the hypothalamus and pituitary then at the ovarian gland. So, at hypothalamus is usually receive the feedbacks of all the hormonal regulations in the body. Even insulin growth factor, insulin growth factor, insulin resistance, or each and every factor such as NEFAs and DHP, beta hydroxybutyrate, and even lower lactate after the pathway. This all gives negative feedback to the hypothalamus and influence the follicular media, leading to disruption of the electrolysis and later form cystic ovarian. ovarian degeneration. Now, what about metabolic stress? So, since there is metabolic stress, any type of stress, whether it's metabolic, we will later discuss about normal physical stress. So, metabolic stress, there will be negative energy management. We are not getting the adequate amount of the rational salt to the animal. It will go with negative energy balance, especially postpartum. So, there will be decrease in insulin and leptin protein will decrease and glucose. So, further effect the negative effect of hypothalamus, there will be decrease in the GnRH production and amplitude and frequency of the GnRH will be decreased. Now, what about physical stress? Once there is physical stress, there will be production of the cortisol levels by the adrenal gland. So, what happens is, along with cortisol, there is endorphins. So, cortisol directly binds GnRH receptor and prevents stress in the GnRH transcription and release. Now, cortisol level also release, there will be release of beta endorphins. So, beta endorphins actually new-opioid receptors in the hypothalamus and later which gives negative effects on the effective neurons which are the primary stimulators of the heart. Now what about at ovarian level? So luteinizing hormone normally as you can see that from pituitary GnRH cells is there, NS cells is there and normal follicle will get ovulation and function of Cysts. But when there is imbalance, as I told you initially that there is inadequate LS at appropriate time in the extra, there will be failure of the follicles to mature and formation of the follicles. And in sufficient cases, in some cases when there is partial or insufficient LS, there will be formation of the nucleus. Now, what about deficit? Similar to the LS, usually the ratio is 2.1 to 1.1 LS deficit ratio, but when there is deficit in this ratio, there will lead to the formation of the more number of follicles in the ovaries and some of them delayed to mature. Now, estrogen level. As you know that it is having the negative feedback on the hypothalamus for LSDC. So, when there will be follicular cyst, there will be high estrogen level, there will be nymphomania, there will be positive feedback to dysfunction and ovulation is corrected. What about cysts? As there is high resistance, you will be normal feeling. So low resistance, low estrogen helps to distinguish them from the follicle. Now, what about progesterone? Progesterone, it is having negative feedback on hypothalamus pituitary. One, and usually expresses GnRH as well as LH. But in case of the cystic ovary, there is lack of follicles, there is lack of insulin, which results in the normal interface of the normalization of the hypothalamus and further to the polygenesis being nymphomania cycle is prolonged. And in these people, there is like action and there will be no all pathogens in the blood that are told. Now, what are the predisposing factors? So, hereditary predisposition. Certain animals can inherit genetic traits like factor hormonal regulation because making them more prone to the cystic ovarian degeneration. What about breeds? High-producing indicators such as posting breed and phosphates have higher incidence of puberty as compared to normal, due to especially due to metabolic stress and age. COT occur more frequently in older and multivariate animals than in parasites because of the cumulative endocrine metabolism. Yield and nutrition. The height in the field combined with the inadequate energy balance and inadequate nutrition leads to negative energy balance, especially the LS and causing an ovulating age. What about season? Cystic ovarian degeneration is more common during the summer season due to heat stress and increased cortisol level, which disturbs the normal reproductive hormone. What about indirect diseases? Diseases such as metritis, mastitis, pedology increase the stress and metabolic imbalance, which causing illness. Now, what are the clinical signs of follicular? As in the follicular stage, there will be increase in the estrogen level, so the animal becomes nymphomania, leading to excessive mounting, hyperactivity, restlessness, increased vocalization, frequency, urination, and increased activity. Irregular or prolonged distress due to the presence of the estrogen, there will be more erratic distress and animal will be incontinent. Sometimes there will be any stress, but as if the estrogen production creates cause of rupture, unlike previously, this anesthesia is not protected, but often intermittent, sometimes it is irregular. Chronic follicular cyst cases due to prolonged estrogen exposure, there will be enlarged uterus, mounting of the anus, massive behavior, goes thick and neck, raised face from the ligament, relaxation. Then ovarian findings, you will find that there will be flaccid uterus. Flaccid uterus, there will be due to the estrogen, there will be flaccid uterus. As it doesn't promote the thickening of the uterus, as it is done by progesterone. You will find the opposite during the ovarian findings. So as I told you, both the ovaries will get enlarged by transactional palpation, and number of cysts will be more in number as the environment. And last one is the decrease. Now what about follicle? There will be anistus due abscess created, white abdomen, persistent infertility, slight movement of uterus and closed follicles. These are the differences between the follicle system and uterus. Now what is the diagnosis? So a person will the farmer will come to you can say, doctor, my now or 2 months ago, and since then she is coming to meet again and again, sometimes every 5 to 7 days. So she becomes very restless, keeps mounting other elements and allows mounting at odd times. Despite repeating examination, she is not getting pregnant. Her milk is good, but she looks very nervous during the day. So what should one suggest? As all the signs here, you can see that nymphomania is there and persistent deep is there. You can suspect that follicular cyst. What about if the person says, doctor, my dog for around 3 months ago but has shown its heat once after calving. She is eating normally, even but no signs of itches are seen. Earlier she used to come to eat regularly, but this time nothing is happened. She has not been examined. And you can see that post-ovulation, where there will be that high level, so it will most and also there will be no any stress here, so you can clearly suggest for fluidicis and distally between the both two cysts as treatment should be considered while these should be now these are the signs. First one is the calving mounting on the other side, this is the sign of nymphomania. Second is elevation of the tail is there, it is too present in the follicles. Third one is aggressive behavior also in the follicle. Now what about the transactional palpation? Usually uterus occurs and there is cyst. Uterus is one ovary. It relates to the deeper formation, but follicular cyst has no GnRH formation in both the ovaries, so there can be number of follicles which are present. So these are important and these are big. Readily burst, follicular cyst can burst while palpating, and whereas uterus is difficult to burst. Vagina, clitoris, vulva, pollen, mostly in the uterus. Now, what about the ultrasonography? I initially told that the structure is usually greater than 70 millimeter, which is usually the method for dominant follicle. The structure can be 25 to 40 anechoic block. Black in case of follicular and ovate like usually hyperactive in case of uterus. And no ovulation structure here is there. You can distinguish based upon the UHG findings that there will be the wall and elasticity in the case of the follicle
utilizes
the fluid density and fluid density anechoic and hypoechoic. Now, what about you can sometimes what happens is one can't differentiate between the uterine and follicular cyst, but at that time we will go for plasma or milk progesterone acid. As in the follicular cyst, animal will mimic estrus, so there will be basal level of the plasma less than plasma progesterone less than 1 mg/ml, and milk progesterone will be less than 5 mg/ml. And in case of the uterus, it will make the pregnancy greater than 3 mg/ml and milk it will be greater than 10 mg/ml. Now what about the treatment? Initially, manual rupture was there, ovarectomy was performed, injection of the ovarian cell extract was given, uterine infusion was there, injection of adenine chloride and uterine was given. But as these are not fruitful, we went towards the hormonal therapy. So what are the current treatment strategies? So as the follicular cyst is present, what should be our approach? We approach from where we give GnRH or H. It will lead to the formation of new follicle. New follicle will dominate, it will utilize and will ovulate and further utilize the formation of the skin. This here will also utilize the utilization of the this is which is irregular, and then we can give AGF12 or we can wait for 18 to 21 days after 3 days.